If you've ever had to navigate treatment options for depression or, watched a loved one struggle, that core question, it can be heartbreaking sometimes. Why does one treatment work wonders for one person but just completely fail for another?
Hmm.
That unpredictability is really quite staggering.
It absolutely is. And honestly, that frustration has driven a huge evolution in clinical research. For a long time, we've mostly relied on one approach, focusing on the brain's chemistry.
Right.
Today, we're really going to explore the other side of that coin, treatments that actually target and retrain brain circuitry.
Okay, so we're zeroing in on the difference between, say, the most common approach medications like SSRIs,
Mhm.
and one of the really exciting advancements, transcranial magnetic stimulation, or TMS.
Exactly.
And the goal here is simple, really. We want to give you the context, the clarity to understand how these two paths work fundamentally and, what they mean for the future of more personalized care.
And we're really pleased to share that this exploration into advanced treatment insights, especially regarding the groundbreaking Blossom TMS therapy system, is brought to you by Sabres Medical.
That's great.
And you can learn more about this FDA-cleared technology at blossomtms.com.
Excellent. So blossomtms.com. Okay, let's start where most people's clinical journeys begin, right? With that chemical approach. We're talking selective serotonin reuptake inhibitors, SSRIs, uh, drugs like Prozac, Zoloft, Lexapro. They're foundational, but how exactly do they work down at the neuron level?
Well, the main goal of SSRIs is to influence serotonin. It's probably our most famous neurotransmitter, and it's critical for things like mood, sleep, appetite.
All the big ones.
Right. So when a neuron releases serotonin into that little gap, the synapse between nerve cells, the SSRI sort of steps in.
It's like blocking the cleanup crew. Is that a fair way to put it?
Yeah, that's one way to think about it. The drug prevents the serotonin from being quickly reabsorbed, that's the reuptake part, back into the neuron that released it. So that blockage means the serotonin kind of hangs around in the synapse longer, increasing the amount that's available to the next neuron.
That sounds pretty immediate, like it should work right away.
Yeah.
But we know it doesn't. You don't just pop a pill and feel better an hour later.
No, exactly. And that's a really crucial point. It shows the indirect nature of this chemical approach. Even though serotonin levels go up relatively quickly, the brain doesn't instantly translate that into a better mood.
Why not?
Well, the receptors themselves, the parts that receive the serotonin signal, they have to gradually adjust. Their sensitivity, their density, it changes in response to that sustained chemical presence. And that process takes time.
Ah, okay.
Usually about 4 to 6 weeks before we see a really significant clinical response.
4 to 6 weeks. And because these drugs are systemic, right, they affect the whole body's serotonin system, not just the brain, the gut, everything. That's where we get those really broad side effects.
Precisely. Fatigue, nausea, weight changes, sexual dysfunction. These are pretty common trade-offs because the drug isn't targeted, it's circulating everywhere.
And that burden can be really significant for people.
It can. But maybe the toughest reality here is hitting that efficacy wall. The data is quite clear. Something like a third of patients with major depressive disorder, they just won't get adequate relief, even after trying 2, maybe more, different antidepressants.
Wow, a third.
Yeah. And when that happens, the patient is then considered to have what we call treatment-resistant depression, or TRD.
That's a really staggering rate of resistance. So knowing that, I mean, if the chemistry approach hits these kinds of limits, the time lag, the systemic side effects, this high failure rate, it really forces us to think differently about the alternative, the circuit-based approach.
Absolutely. I mean, the need to effectively treat TRD is really what pushed forward this whole era of neurostimulation. We're moving past just bathing the brain in chemicals globally and focusing instead on the physical electrical activity, the patterns of the neurons themselves.
And that's where TMS comes in, transcranial magnetic stimulation.
Exactly.
So how does it actually do that? Without, surgery or needing sedation, it sounds almost sci-fi.
It's actually based on some beautifully simple physics.
Yeah.
The clinician places a special magnetic coil over a very specific part of the patient's head.
Good.
And this coil generates strong, focused magnetic pulses. These pulses pass completely harmlessly through the skin and the skull.
Right through.
And they induce tiny electrical currents directly in the brain tissue just underneath the coil.
So you're basically creating a little bit of electricity precisely where it's needed. And that target spot, that sweet spot, is the DLPFC.
The dorsolateral prefrontal cortex.
Yeah.
And understanding what that part does is really key to understanding why TMS works for depression.
Okay.
The DLPFC is kind of like the brain's cognitive control center. It handles executive functions, planning, but critically, it also acts like a brake or maybe a dampener on the deeper parts of the brain, the limbic regions, which generate raw emotion.
And the idea in depression is that this area, the DLPFC, is often underactive. It's not putting the brakes on the emotional centers effectively enough.
Precisely. It's like the communication is weak or faulty. So the goal of TMS stimulation is to, well, strengthen or normalize those communication pathways between the DLPFC and those deeper limbic areas.
Oh, I see.
We're not trying to flood the brain with a chemical. We're directly trying to correct a functional issue in the brain's wiring, its circuitry. And that fundamentally different targeted mechanism is why TMS is FDA cleared specifically for treatment-resistant depression.
That really is a powerful distinction, isn't it? That sort of global chemical adjustment versus a very local physical electrical tune-up. And that difference in how they work must have massive consequences for the patient experience. Let's maybe walk through those key comparison points now.
Sounds good. I think the first one, and maybe most compelling for a patient who's really been struggling, is the time it takes to see an effect.
Right. We mentioned the SSRIs take that slow receptor adjustment, 4 to 6 weeks, you said.
Yes, 4 to 6 weeks of taking it daily before you typically see measurable changes.
And that, gosh, it can feel like an absolute eternity when someone's severely depressed. It often leads to people just giving up on the treatment too early.
It really can. Now, in stark contrast, because TMS is directly modifying those communication patterns, patients often start showing measurable progress, sometimes even just reporting a shift in how they feel or perceive things within about 2 to 4 weeks of consistent sessions.
2 to 4 weeks versus 4 to 6. That faster response potential, that's clinically huge.
It's incredibly important.
Okay, next point. The side effect profile. This seems like where the difference between a systemic drug and a localized pulse would really show up.
Absolutely. With SSRIs, you're potentially managing continuous body-wide side effects. It's a daily commitment, and those side effects can impact quality of life for years sometimes. Sleep, digestion, libido, weight.
Yeah, the list is long.
It can be. Whereas with TMS, the side effects are generally localized and temporary. Usually it's just some mild scalp discomfort or maybe a slight headache right around the time of the session itself.
And critically, there's no sedation involved. No memory issues, no fogginess.
None of that. No sedation, no cognitive impairment, zero downtime. You literally finish a session, which takes maybe 20 to 40 minutes depending on the protocol, and you can drive yourself right back to work or whatever you were doing.
That is a massive difference. Just avoiding that systemic burden of daily medication must be a huge relief for many.
It represents a really significant shift in the quality of care, yes.
Okay, and the final point. Long-term outcomes and commitment. If you stop taking an SSRI, there's often that risk of withdrawal or the depression coming back, right? You often have to take it continuously.
That's a major factor, yes.
Huh.
Maintaining the results often requires continuous medication. With TMS, though, we're talking more about durability. The goal isn't just symptom management, it's aiming for genuine neural restoration, actually retraining those circuit patterns.
So the effects might last.
That's the aim. Because of this mechanism, the benefits often continue even after the initial course of treatment ends. Now, some patients might benefit from occasional maintenance sessions down the line, but it offers a non-pharmacological approach that, for many, seems to result in a more durable, sustained period of relief compared to medication alone.
Okay, so if we kind of zoom out and connect this to the bigger picture, who is actually getting this advanced circuit-based intervention today, and what does it signal for clinical practice maybe tomorrow?
Well, right now, TMS is primarily used, as we mentioned, for patients who meet that criteria for treatment-resistant depression. People who've already tried typically 2 or more antidepressants without getting significantly better, for them, switching to a circuit-based approach like TMS can be genuinely life-changing.
But the shift is bigger than just TRD, isn't it?
No, absolutely. You're seeing the rise of what's often called interventional psychiatry.
Interventional psychiatry.
Okay. Exactly. Clinicians are steadily moving away from the older sort of trial and error method, which relied heavily on just subjective patient reports. How are you feeling this week? And moving towards more multidisciplinary plans. Plans guided by objective biomarkers, actual measurements of brain function, that's the crucial game changer.
So using technology to actually map the brain, maybe see where the communication isn't working quite right, and then targeting that exact spot with something like TMS, instead of just guessing which chemical tweak might help across the board.
That level of personalization is the new generation of care. We're definitely moving toward a model where clinicians can map a patient's unique neuroprofile, identify specific connectivity issues, and then deliver stimulation tailored precisely to those individual needs.
Wow.
This is really what we mean when we talk about moving beyond just managing symptoms towards achieving genuine neural restoration.
So the core insight here, it seems, is that depression isn't just a deficiency of one chemical like serotonin. It's maybe better understood as a functional issue, maybe a failure in key brain circuits.
That's certainly the direction the research is pointing.
And once you accept that framework, the path forward becomes less about these broad chemical adjustments and much more about precise, targeted electrical recalibration.
Which then raises a really interesting question, maybe for you, the listener, to think about. If we can potentially achieve genuine neural restoration by correcting circuits, rather than just masking symptoms chemically, what does that imply about the physical, the biological nature of depression itself? And maybe even more broadly, what possibilities does this whole circuit-based understanding open up for potentially treating other complex mental health disorders in the future?
That's a fascinating thought to leave people with. And the technology driving this critical shift, moving towards precision, towards durable, non-drug solutions, is advancing incredibly quickly. To learn more about this FDA-cleared technology, like the Blossom TMS therapy system we mentioned, you can visit blossomtms.com.
That's blossomtms.com.
Brought to you by Sabres Medical.